Thank you. It's great to be with you here today. And I don't know about you, but I thought we had some fantastic presentations before coffee. I think William, setting out the why and then some brilliant examples of how with Birmingham and Essex. But what Tracey and I want to do is really get across the message that you really do have to take a partnership approach to creating the ecosystem that's required for social prescribing to really address health inequalities and make its greatest impact. And what we want to do is really help show it doesn't matter where you are in the country, how you can get started and make progress. And I think one of the big messages about systems change, and we heard so much about a systems approach before coffee, is that you just have to start somewhere and follow it everywhere. No system around the country is a perfect system. Certain people will have stronger health partners, stronger local authority partners, stronger voluntary sector partners, stronger physical activity partners. But we're just sort of saying this is how you can get started around the country. So I'll just start off with setting out a little bit about what's the government policy and the context for where we are. So many of you in the room will have heard of personalised care. This is one of the 5 key changes for all health and care systems across the country. And there was commitments in the long-term plan to delivering personalised care. And personalised care is really, really important for the reasons that William and others set out before. Because although medicine is really important, and we saw that through the pandemic with vaccinations and various bits of medicine, it's not the whole picture. If we're really serious about improving people's health and well-being in the country, we have to take that holistic approach. I'm an OT. It's fantastic to be at the Royal Society of Medicine. And, 30 years ago, I was trained in a holistic biopsychosocial approach. It is so exciting to see that movement now and that understanding. So really, really critical. People need agency, purpose, choice and control over their lives, and connection. This is the way we're hardwired as was set out before the break. So personalised care is a really practical way of doing that. 6 key components that help to address and give people more choice and control and connection. Today I'm going to be talking about social prescribing, but they also include things like supported self-management, personalised care and support planning, personal health budgets, and a few other areas. So personalised care had very ambitious targets in the long-term plan, 2.5 million people to experience personalised care by 23-24. And we've already exceeded that for people. And so in the Secretary of State's reform speech on the 8th of March, he set out more ambitious targets for personalised care, whereby 4 million people will benefit from personalised care approaches by 23-24. And I'm really pleased to say that that includes referrals to social prescribing and the amount of social prescribing link workers we have around the country. And so we will be setting more ambitious targets for social prescribing, as we've already exceeded those 900,000 people referred to social prescribing that were set out for 23-24. So personalised care has 3 key roles in primary care. It has a social prescribing link worker, a care coordinator, health and wellbeing coordinator, coach, and we're looking to roll those out across all primary networks in England. And social prescribing, we've had a really exciting journey so far. So this isn't new. It was happening in the voluntary sector and the local authorities. But what we've been able to do is add additional link workers into the system. So now every primary care network, that's a collection of GPs of 300 to 500,000 people population, have to have offer access to a social prescribing service. And that often means by primary care networks recruiting social prescribing link workers, hosting them in VCSE organisations or hosting them themselves. And so at April 22, we had over 2,500 additional social prescribing link workers in primary care. So we're really building that infrastructure for people to be able to connect with and build across the country. So I've just got a couple of really key messages of how do you make this work. So your link workers can do exactly the things that William talked about before the break. Help people really focus on what matters to them. People won't engage in physical activity unless it's something that really motivates them, that they're interested in. It might be that they're more interested in nature, so you can connect people into that. It might be, and we have physical activity and arts as well, we can connect people into that. But also what your link workers can do is really understand some of those wider determinants that are really getting in the way of people's health and well-being. If people are worried about their debt, if they're worried about housing, if they're worried about their relationships, they need help to be able to address those issues. And that's particularly true for, as we've heard, for people who are most at risk of health inequalities. So link workers, they spend time with people. They don't just signpost, they'll actually help people connect. That might be going along with, it might be finding peer support, it might be finding volunteers. So they can do those things that actually help people who are furthest away from connecting with physical activity, develop knowledge, skills and confidence of how to manage their condition, tackle barriers, so accessing the equipment, whether it's the right shoes or whether it's the right wellies for a nature activity or whether it is bikes, as we heard before. Address those wider determinants and help people find activities that are going to be right for people in the community. Because what they do is they don't just see people on a one-to-one, they actually spend time with those community groups to understand the quality of the community activities that they can connect people to, and they nurture community groups. And so we've been building the workforce for link workers. We've got a strong workforce framework, competency framework, lots of free training and development. And we're building the workforce in primary care of their understanding of this approach and working with our voluntary sector partners there. I think one of the really important messages I want to give you is that it's so important if we want to address health inequalities, and we saw the case for the absolutely, it was important before, but my goodness, post-pandemic, this is essential. And the way to do that is proactive and targeted approaches to social prescribing. So if we just leave it to who turns up to their GP, then what we'll see is the inverse care law, at large, where people who need it most, who may not be engaged with primary care, aren't actually accessing social prescribing. So this year, through the primary care DES, we have developed a proactive social prescribing service specification, which is encouraging primary care to really look at who is most at risk of not reaching social prescribing and most in need of it, and how do you start to work proactively with those communities to co-produce that offer. And finally, it requires an ecosystem to survive. It needs all of those partners, and I'm going to leave Tracey to talk more about the strategic approaches. But the place-based working in our integrated care systems provide us this opportunity. So you'll probably be aware with the Core 20+5, this is the NHS England's advice to ICSs about how to tackle social health inequalities. So really using population health management data and soft intelligence from working proactively with local communities to identify who is most in need. In that 20% of people who are living in most deprived areas, people in those plus groups, that might be health inclusion groups like gypsy travellers, could be people in minority and ethnic communities, could be people with specific long-term conditions or mental health, for example. And then there are 5 key particular clinical areas of focus which have got significant areas of health inequalities. We've got a very extensive support offer at NHS England to help people try and deliver social prescribing and embed those link workers. So that'll be in your packs and coming round to you. And I'm now going to hand over to Tracey, who's going to talk to you a little bit more about taking a systems approach and how we build those strategic partnerships to help social prescribing thrive and address health inequalities.
Thanks, Nick. So, afternoon, everybody. Thank you to Nick. So, I work for the National Academy for Social Prescribing. Some people might think, what on earth is that? It's not been around that long. But I have worked in physical activity for, too many years, I think. I think my first job was about 25 years ago, actually working on what was not called social prescribing then. It was called community referral. So it's quite interesting how things have changed and we're starting to work in those ways. So my role is funded by Sport England, and I work in National Academy, and as it says on the tin, I lead for physical activity. And we've started to think about, well, how do you actually move away from silos to systems? Because predominantly, there's loads of brilliant programmes out there, loads of brilliant work that you all do. There's things that say, well, we do this and we've got the evidence on that and this is how it all works. But how do we actually link the systems together, and how do we enable people to work more and co-produce and collaborate together? So all what was spoken about this morning is so, so important, and very much so with social prescribing. The classic question I get asked every day is, Tracey, how do I talk to my link workers? And actually, it's much more than that. It's about thinking about the system and how you work with the system, not just the link worker. The link worker is a person within the system, but how do we actually work with our health system? So through the National Academy, we want to make some noise and raise the profile of social prescribing. We look at finding resources and helping support people, and most importantly, about how we build relationships. And I'm going to explain a little bit of the work that we're doing now around building those relationships at national, regional and localised level. And obviously also improving the evidence base linked to social prescribing is very, very important, and spreading what works. So hopefully you'll see that we're going on a journey, on a trajectory to think about, well, what does really work well? What are the resource requirements that's needed? What resources are already out there? And how do we interlink and build things better together? But it is really about moving and collaborating. Many people come to me and talk about social prescribing and say, we offer a brilliant service. How can we tell our link workers to refer to us? And actually, it's about moving away from that. It really relies on thinking about how you can build really mature, strong relationships with, if you're in place, your primary care network or your ICS or your ICP, understanding what your local health priorities are and looking at how you can collaborate and work together to think about how you can address them all together, rather than we'll come to you as a customer or tell you what we can provide. How can we really work and work in those ways? The one thing I want people to think about is health itself has gone through a huge transformation. It's gone through a huge transformation, and now they're looking at primary care networks, networks of people working together. How does the physical activity and sports sector work together to connect with those networks and work as one? And that's something that we're really trying to move forward with. But not only that, we heard in William's talk earlier, it's not just about the physical activity intervention. How do we work with other organisations, those organisations that work in areas of health inequality that really reach people? How do we encourage traditional providers of sport and physical activity to connect with nature, to think about that real social side? How do we think about a much more holistic way of working? So how are we going to break down those silos between those statutory and voluntary sector organisations that are so key in communities? And how can we support those smaller organisations that, as a result of the pandemic, have really started to struggle? And we know that funding is very difficult. Who can we work with? There's not going to be necessarily more money. It doesn't mean that we can run to the commissioners in the ICS and say, what can we provide us? But how can we think about building our resources differently? And most importantly, what matters most to communities and what matters most to our sector to enable it to thrive and really drive forward and show its worth, because we know physical activity is very, very powerful. So we are testing and we are learning. There's been 37 programmes across the country through Thriving Communities funding that was disseminated through the Arts Council in partnership with National Academy for Social Prescribing, and that went through the pandemic. Some of those programmes are coming to an end, and they really were test and learn pieces to understand what parts of the system need to be connected together. Where's it really hard? Where's it really difficult? Well, how can we enable and move things differently? We're also looking at 7 test pilots across the country around green social prescribing, and looking at the power of green social prescribing around mental health, and looking at how that can be used and worked in different ways. Every pilot is trying something different, looking at different ways of working across blue and green to think about how they can work. And we're also starting to look and consider about other pilots. So what's starting to emerge, which will lead lovely into Jenny's talk later, is we're also looking with Department for Transport at looking at active travel social prescribing, which we've heard also about this morning. So really starting to think about those connections. The difference is, it isn't about saying what the actual providing the programme is, it's how the connections, we're learning about the connections and how we actually work in a collaborative, systems-based approach. So from NASP, the National Academy, we've started to lead on a piece of work in partnership with Sport England, with the EFL Trust, the NHS, a number of active partnerships, and we are looking for more partners and considering how we can work together on this learning journey. Why this came about was social prescribing, pre-pandemic, was reaching mainly females. So how do we reach males in areas of health inequality? And how do we really reach in and utilise the power of sport and physical activity? We look towards football. And when I say football to NHS colleagues, they think about that 11-a-side game on a Saturday. They don't think about all those hundreds of community trusts that we've got across the country that are doing excellent work around mental health, cancer recovery. I've seen a child and adolescent mental health programme, loads and loads of different work that they're doing. And started to say, hey, do you know that they do this? And they were like, no. So what we've started to do in partnership with NHS England is I'm working with the NHS Prevention Team, NHS Health Inequalities Team and NHS Personalised Care Team. And we're working together at a national level to understand one another and think how can we interlink and work in a more systems-based approach. We're then taking that learning and we're working down with, we've identified across the country a number of key ICSs which are in levelling up areas to look at where can we actually focus and work with, at this stage, Community Football Trust, to think about how we can alleviate and work together on addressing health priorities. Why Community Football Trusts? Because they're large charities. Not because it's just football, because they do a large amount of different work. But also, Sport England said, hang on, we've got some Active Through Football money that we're disseminating across the country, and we're trying to look at how we build collaborations. Can we come on that journey as well? So we've started to bring and knit people together to think about how can we all work collaboratively and look in local places down in PCNs in areas of health inequality where we can start to develop a real kind of programmed, place-based approach. Work together to develop a plan. It doesn't matter whether you're working with a smaller organisation. It's not about competing with one another. It's about how we can collaborate and enable and support. We have seen some excellent work through Community Football Trusts. The West Ham Foundation down in London have done some amazing work around health prevention, and they now have a consortium of 40 partners that all work together, that then have a single point of entry that enables health to go and talk to that one organisation that then can all talk to others. So how do we make it simple for our health colleagues who have gone through a really difficult time, they're going through change and going through challenge, and how do we bring that together? So More Than a Game is looking to do that. We're on a really early starter. We've got the areas of the country identified. We've done some very detailed mapping around that. We're starting to look at Core 20 connectors. We're looking at link workers, primary care networks, healthy lifestyle coaches, and we're trying to understand what the system enablers and the system blockers, as well as the other learning programs that we're doing. But you could be a partner in this. You could come along on that learning journey. It could be you could be a certain partner working in a place, and you say, oh, actually, we work in that place. We're going to show the areas in the next couple of weeks when we'll be launching the programme. So it's very new. It's about how we work together, and it's about how we look at more that systems-based approach. Because it's very easy to work in systems and see it on a piece of paper and think, oh, how do we do that? But we want to take community trusts with us. We want to take community organisations with us, primary care network development managers, link workers, GPs along that journey, and say, how can we work collaboratively together and understand, most importantly, what works and what matters to them. So just about the client, but also what matters to our sector and what matters to health. So that's More Than a Game. If you want to talk to me that lovely hour over lunch, I'm around, so please do, and hopefully we can connect. Thank you.
Thank you so